Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. Today, as part of our official coverage of the IAS 2025 conference, I'm joined by our two expert faculty who are going to bring us through their most important studies from the conference. I'm joined by Dr. Beatriz Grinsztejn from Rio de Janeiro and Rosie Mnggibisa from Durban, South Africa. To follow along with the slides, see the link in the show notes. Now let's get started and hear from Dr. Grinsztejn.
Starting with updates on Purpose 1 and Purpose 2, the two phase 3 trials that evaluated twice-yearly subcutaneous LAN for HIV prevention. Lenacapavir, as you know, is a first-in-class long-acting HIV-1 capsid inhibitor offering a promising alternative for HIV prevention globally. Recall that Purpose 1 was a randomized trial of lenacapavir as compared to either FTC-PAF or FTC-TDF in sub-Saharan Africa and enrolled cisgender women aged 16 to 25 who were sexually active with cisgender men and had no prior use of PrEP or PrEP in the past 3 months. These were entirely an adolescent and young adult population. And then Purpose 2, that was a global trial that included cisgender men, transgender people, and gender non-binary individuals aged 16 and older who had sex with a partner assigned male at birth. This was just a 2-arm study comparing LAN with FTC-TDF. Of course, the lenacapavir after initial oral loading dose was given by subcutaneous injection every 6 months, whereas the FTC-TAF or FTC-TDF arms received a daily oral PrEP. And you can see there were more than 5,000 people enrolled in Purpose 1 and nearly 3,300 people enrolled in Purpose 2. So this design allowed us for the assessment of safety and efficacy in highly diverse populations of adolescents and young adults. With high potency and a long half-life, twice-yearly subQ LAN has shown efficacy, safety, and tolerability in these diverse populations. So youth aged 15 to 24 accounts for roughly 28% of the 1.3 million new HIV infections each year, but they face significant barriers to starting and staying on daily oral PrEP. So while ethical and regulatory safeguards are intended to protect adolescents, they often delay access to critical innovations. A more balanced, inclusive approach is essential to ensure timely, equitable prevention options for this vulnerable. So in Purpose 1, to be clear, which was limited to adolescents and young adults, there were no new infections acquired after the start of the trial in the lenacapavir arm, compared to 39 infections in the FTC-PAF group and 16 infections in the FTDF. This corresponds to an HIV incidence of 0 per 100 person-years in the LAN. Not a statistically significant difference between the two oral arms, but obviously a highly significant superiority for lenacapavir. And then in the Purpose 2 study, which really included a larger group of people, not just adolescents and young adults, there were only 2 infections acquired after the initiation of therapy in the lenacapavir arm. As it turns out, both of those infections occurred in adolescents and young adults, but that was once more substantially and highly significantly lower than the 9 infections acquired among those participants in the FTDF arm. So these 2 studies combined demonstrate the superiority of every 6-month injectable subQ LAN compared to daily oral PrEP. In both studies, background HIV incidence in the community was over 2 per 100 person-years, highlighting the high effectiveness of LAN in real-world high-risk settings. The summary of adverse events among youths and young adults receiving subQ LAN in Purpose 1 and 2. And overall, what we see is that adverse events were common, but mostly mild to moderate. And serious adverse events and discontinuations due to study drug were rare across all age groups. Adverse events and lab abnormalities were generally comparable among youths receiving LAN in both studies. And very importantly, injection site reactions were mostly low grade and aligned with what has been reported in adults. These reactions were well tolerated and resulted in very few discontinuations. These findings support the safety of LAM among adolescents and young people with a profile similar to that observed in older populations. As we look to the future of HIV prevention and treatment, it's critical to consider not only scientific advances, but also the sustainability of the systems that support. And so one of the real challenges we face now in the prevention road is that with the funding cuts that have occurred due to the dissolution of the USAID and severe cuts to PEPFAR, there's really enormous concern about what this means for efforts to control the HIV epidemic in low and middle income countries. So Boring and colleagues presented us the projected impact of anticipated international funding cuts, in particular, the potential discontinuation of PEPFAR on the HIV epidemic in low and middle income countries. So they presented the results of a quite interesting modeling study using the optimal model to estimate the impact of prevention and acquisition of HIV. The analysis used country-validated mathematical models that simulate HIV transmission care and resource allocation to estimate outcomes under different funding scenarios. These models were applied to 26 countries, representing nearly half of all people living with HIV in LMICs and 54% of the reported PEPFAR funding. These models estimated that by 2030, a 24% cut in international aid could result in up to 1.7 million additional HIV infections and 61,000 additional deaths. The projected impact of PEPFAR discontinuation is even more severe, potentially leading to up to 10.8 million additional infections and 2.9 million additional deaths over the same period. Sub-Saharan Africa, which receives the largest share of PEPFAR funding, are among the most vulnerable to reductions. While national health systems may preserve HIV treatment and facility-based testing prevention services and community-based testing, which rely heavily on international aid, are at greatest risk. So these findings highlight the urgent need for coordinated global efforts to safeguard HIV service continuity. Without mitigation, these funding cuts could reverse decades of progress, especially among key populations and children. So our key takeaways with respect to HIV prevention are that in the Purpose 1 and Purpose 2 studies, the efficacy of lenacapavir and its safety in adolescents and young adults were similar to those seen in adults. The impact of budget cuts on the HIV epidemic was shown to be extensive in this modeling study that I just presented, with potentially dramatic increases in the number of HIV infections and deaths attributed to HIV, all associated with decreased foreign aid and the discontinuation of support from PEPFAR, with sub-Saharan African countries being the most vulnerable and HIV prevention services suffering the greatest impact. So now, let me turn this to Dr. Mngqibisa, who will talk to us about antiretroviral therapy studies.
The first study I will talk about is the Breathe Plus study, which is a study that was focused on a strategy to try and address the adherence in adolescents. We all know that the adolescent population is a vulnerable population, is a population that is at risk of having suboptimal adherence, which leads to poor virological outcomes. And we know that it's a population that is likely not to even come close to meeting the 95% US targets. So strategies are needed on how to support this population to achieve and maintain virological suppression. So the Breathe Plus study looked at a strategy of giving time off ARVs for adolescents. So they refer to that as a short cycle therapy, where participants that are enrolled on the study are given 2 days off. They will take their treatment Monday to Friday, and then they have Saturday and Sunday off, versus continuation of therapy or daily therapy to prove the main aim was to see if short cycle therapy, which I will refer to as SCT, is non-inferior to continuous therapy, which is CT. The study was conducted in sub-Saharan Africa. It was a multi-center, open-label, non-inferiority trial conducted between June 2022 and it closed this year in June. They enrolled adolescents aged 12 to 19 who have been on ART for more than a year, who are currently on dolutegravir 3TC and TDF, TLD, for at least a month. They excluded everyone who had prior failure, everyone who had a viral load that is above 50 copies per mil, and any pregnancies or breastfeeding. So the study randomized 1-on-1 to either the SCT or the CT. So 239 were randomized to SCT, whilst 231 were randomized to CT. Their visits were every 8 to 12 weeks. There was real-time HIV RNA testing 6 to 12 months, depending on country guidelines. Other samples were stored and they were tested retrospectively for other visits. The primary endpoint for this study was a confirmed viral rebound by week 96. And these secondary endpoints also looked at safety and adherence. In brief, the baseline characteristics of the enrolled population, the median age was 16.5, and most of the participants that were enrolled acquired HIV vertically, 97%. They largely females at 56%. The median time on antiretroviral therapy was about 11 years, and the median time on dolutegravir was 2.5 years. The event rate that was used for the study was 5% based on the events that occur in the continuous therapy. So the rate of 5% meant that the non-inferiority margin of 8% with 99% confidence interval. The primary analysis of the study showed that 23 participants on the short cycle and 11 on the continuous cycle met the virological rebound by 96 weeks. And this led to a 5.1 risk difference, which was, well, even though slightly, it was higher than the 5% that was meant or predetermined by the study. Because this showed to be higher than the event rate when you're using the 99% confidence interval, the SCT was deemed inferior to continuous ART. The study continued to look at resistant mutations for participants. Firstly, it's important to note that there were very few mutations. The mutations were mostly the NNRTI mutations. One participant who had an INSTI mutation had also an RTI mutation, which is 3TC. They had high-level resistance to 3TC, and they had resistance to an INSTI. That was the only one participant who had resistance to INSTI. So I will move on to the next study. We all know the importance of long-acting antiretroviral therapy in the treatment maintenance. The Impala study, which really builds on the evidence provided by the CARES study of using long-acting antiretroviral therapy in an African setting using a public health approach. The Impala study focuses on patients who had a history of virological non-suppression. The study also provided evidence of those with previous exposure to hepatitis B and also provided a large number of women. So the Impala study is a 48-week study which was a multi-center, open-label, non-inferiority phase 3B study that was conducted in 3 countries, Uganda, Kenya, and South Africa. It enrolled with adults who are more than 18 years old, who have had a history of non-suppression or non-adherence as determined by having had a viral load more than 1,000 in the prior 2 years. A history of loss to follow-up for at least 4 weeks in this time, and also participants with delayed linkage to care after diagnosis, failed link or delay of more than 3 months. This study excluded those that are receiving the second-line antiretroviral therapy. It excluded pregnant women or breastfeeding women and participants with a hepatitis B surface antigen that was positive. They were screened for those that were not suppressed. Suppression defined as a viral load of less than 200 copies per ml. They were kept on dolutegravir-based regimen until the viral load was less than 200 copies per ml. They were then randomized to a long-acting arm. 271 was randomized to LA arm versus a TLD, which is 269. They were followed on the study for 24 months, and the end of the study, the drug companies offered to provide post-access treatment for about 4 years to those who were randomized to the CAP-LA arm. The primary analysis was based on the ITT, the exposed population, and the primary endpoint is a proportion of participants with HIV RNA less than 50 copies per ml at week 48, based on an FDA snapshot and a 10% non-inferiority margin. There were key secondary endpoints, which are HIV RNA more than 50 copies per ml, confirmed HIV virological failure of HIV RNA more than 200 on 2 consecutive occasions, which are at least 4 weeks apart, also looked at safety and participant-reported outcomes. The team also did a sensitivity analysis looking at proportion of participants with confirmed viral load of at least 1 RNA of more than 1,000 copies per ml. So the median age for the enrolled population was 40. 99.6% were women, and we had 31.1% who had Hep B4 antibody positive. The BMI, there were 22% of enrolled participants with a BMI of more than 30. Majority had prior NNR TI exposure. 26.8 had a prior AIDS-defining illness, and the median duration of those enrolled on ARTWAT was 7.5 years. The CAB-LA arm did very well, with 91% of the participants in the CAB-LA arm versus 89.2 on the oral ART, meeting the endpoint of less than 50 copies of RNA. The ITT group focused on the BMI. There's not differences on BMI for response to therapy. We know that with LA long-acting treatment, one of the factors associated with failure is a high BMI. Here, there was no significant differences. Individuals that failed on the CAP, there was only 1.9, or there were 5 individuals, which is 1.5 or 1.9 of the entire population. There were none in the oral CAP. The study retention was very good at 99%, and 98% of the participants on study received their injections within the specified window. Now, delving into the participants that have had virological failure, their characteristics, 2 of them were subtype C and 2 were subtype A. We only had baseline resistance for only 2 of them, and 1 had high-level rilpivirine resistance mutation. And if you look at the mutation for these participants, a large number of them, of the 5, you look at some had high-level rilpivirine, 3 had high-level rilpivirine mutations, and also 4 had high resistance to cabotegravir, which really explains why these failed. We couldn't have resistance testing for 1 as there was insufficient volume of the sample. 4 of them were put on TLD, with 1 put on lopinavir, and all re-suppressed. There were really not much differences in terms of adverse events between the 2 groups, and most of the adverse events that occurred were grade 1 or 2. Most of the injection site reactions that occurred did not lead to discontinuation of treatment. The study had 10 pregnancies, 6 occurred in the LA arm, and 4 of the participants elected for termination. There were 2 live births, and both babies were tested negative. In the oral arm, there were 4 pregnancies, 2 elected for termination, 2 live births as well, and both were negative. When we looked at the study, looked at patients' preference of treatment, there was an overwhelming 94% that reported that they prefer long-acting ART over oral ART. The question around use of long-acting ART or dual ART in participants with Hep B, the team decided to do this sub-analysis to look at participants who developed Hep B during the study. Was there a risk of Hep B reactivation, especially to those who had Hep B core antibody positive? There were only 7.8 participants that were enrolled that had vaccine-mediated immunity at baseline. So on the Hep, for the results that we had, there was only 1 incident Hep virus infection. A lot of participants had immunity, whether it was vaccination or previous infection. HB core antibody negative. There's hepatitis surface antigen negative, which is 165. The next bullet point is supposed to be hepatitis surface antibody positive, which is 20 and 22. Delving on the one that had incident hepatitis B, this was a 32-year-old male who was on the LAN-CAP arm. The vaccination status for this participant was not known. They entered the study with the low viral load, and the viral load was low. It was suppressed even during the incident, Hep B incident. They experienced significant liver enzyme elevation at month 12, and they confirmed that he had a new hepatitis B virus infection, although they were asymptomatic and the liver ultrasound that was performed was normal. This participant was switched to dolutegravir, TDF, and 3-TC. His LFTs improved within 3 weeks, and the hepatitis surface antigen was negative in 6 months. So it was really an acute infection. And it's really important that we do monitor the incident Hep B infections in participants that are, especially with the field moving toward dual antiretroviral therapy, that do not have cover for Hep B. We need to start thinking about how these patients would be managed and which patients are at high risk of developing Hep B reactivation. This study was very reassuring. There were no Hep B reactivations at all. There was just 1 incident, new Hep B infection. So I think we need to promote Hep B vaccination for all participants that are not vaccinated, that are enrolled on TDF or GTC sparing regimens. So another issue that needs to be addressed is the issue of pregnancy on new antiretroviral therapy. There is an antiretroviral pregnancy registry that reports pregnancy outcomes and overall on all women that are exposed to ARVs. This registry usually have reported information from 75 countries, mostly in developed countries. There's still very little information from low to middle income countries. I would focus cap exposures, and this information is through until July 24. So the reported pregnancies on women on CAP were 42, and the majority of them, more than 80%, were live births. There was only one stillbirth, and 3 spontaneous abortions, and 4 induced abortions. So when further analyzing the 42 pregnancies, there were 43 outcomes, with one of the pregnancy being the twin pregnancy. Most of the individuals were already on PAB before they conceived, and 27 of them were exposed 0 to 6 months prior to pregnancy, and a whole lot of them 12 months and over prior to pregnancy. There was only one reported congenital defect among all the live births, and this was congenital ptosis. Among those live births, 33 of them, there were no defects. However, there were some reported preterms, so 5 preterms, 3 had low birth weight and 3 had very low birth weight. The investigators concluded that this finding reflects a positive safety profile, but the results, they warned that the results should still be treated with caution due to a limited number of pregnancies on these drugs thus far. I thought I'll touch briefly about these 3 promising new drugs. The first one is the HRS 10071, and there was a study that was presented quite well by Dr. Pumasamy, which is a phase 2A proof of concept study in treatment-naive people with HIV using this novel maturation inhibitor. And this drug demonstrated a statistically significant reduction of HIV viral load levels versus those of the placebo over a 14-day monotherapy period. And the responses, or the log drop of the viral load, increased with the increasing dose. So the plan is to move to the next phase of study to find the correct dose and to look further onto the safety. The second drug is the MK8527. This is an exciting drug which promises, which also has promising results. It was a phase 2 study looking at an oral once monthly dose of MK8527, which was given for 6 months, testing 3 doses, 3 milligrams, 6 milligrams, and 12 milligrams in people at low risk of HIV exposure. The results that were reported was that this drug was well tolerated across all dosing levels and showed similar safety profile to placebo. Most of the drug-related AEs were grade 1 or grade 2, and they resolved even on study. There were 2 participants that discontinued the drug for the pre-specified immunological criteria, with resolution within 11 weeks of discontinuation of the study drug. The other study is the Moderato trial that was conducted in West and Central Africa. This demonstrated non-inferiority. It actually compared dual therapy to the 3-drug regimen. So it used DTG and 3TC and a PI boosted atazanavir plus 3TC, and comparing to the 3 drugs. And it demonstrated non-inferiority of dual regimens versus the 3-drug regimens. In the era of looking for regimen, TDF sparing regimens because of renal toxicity or bone toxicity, it's important that we explore such regimen, and it's good that there's focus on those kind of regimen. The last study looked at once weekly ulonivirine plus islatravir in virologically suppressed adults living with HIV. So the ULO is a new NNRTI which has higher genetic barrier, which is active against a virus that has resistant mutations towards earlier NNRTIs. So it was a double-blinded, active controlled randomized phase 2b trial. It enrolled adults suppressed on ARVs for longer than 6 months. These adults should have been on big TEF and FTC with CD4 counts of more than 200. They excluded those with a history of virological failure. They excluded those who had resistance to NNRTIs. They excluded those with hepatitis B and hepatitis C co-infection. They were randomized to either 100 milligrams, 200 milligrams, and 400 milligrams of ULO, and others were kept on a big TEF and FTC. This drug showed a really good virological suppression across all doses, and which were comparable to bictegravir. If you look at the week 24 data, it was 100% virological suppression for all the participants that were enrolled on study. The AE were minimal, and mostly they were a grade 1 or 2. There was a grade 3 toxicity, which was mostly on the 200 milligrams, and there were no AEs that led to discontinuation of the study drug on the lowest dose, but by far there were very minimal AE that led to discontinuation of a study drug. So this is a promising entity, and the plan with this is to really pair it with islatravir. Islatravir, we know from previous study, the higher dose of islatravir led to decreases in lymphocytes and CD4 count, and even the lymphocytes and CD4 count here are suspected to be related to islatravir. And the next phase of the study will study a lower dose of islatravir. Key takeaways was that the breather study, disappointingly, the short cycle was inferior to continuous daily therapy, which we have to counsel wisely that our adolescent patients that they cannot not take their treatment daily. They need to be on a daily treatment. Adherence and adverse events were similar between both arms, and the major CO NRTI mutation was only seen in one participant. The Impana study showed us very exciting results that the cabrolipine LA every 2 months was non-inferior to daily TLD in those with prior suboptimal viral control. The pregnancy registrar as well, it's looking good. There's not major safety alerts, having only seen one patient who's been reported to have a congenital abnormality. And then the last study with the ULO islatravir, it's really exciting. It creates more options for less frequent dosing of ARVs, and it's going to be paired with a lower dose of islatravir, which we are hoping will be the next thing because we know it provides choice to participants. Not everyone prefers injections. So if you have an oral once weekly, that might be a preference for a lot of patients generally. So I will now hand back to Dr. Grinsztejn to continue with patient management.
Thank you so much, Rosie. Now we will move on to patient management. So we will look on how recent evidence can guide real-world HIV care and decision-making. So the first of these studies was AIDS Clinical Trials Group A5391 study, also known as the Do It trial, which was a study of switching to doravirine with or without tenofovir fumarate versus continuing in an INSTI-based regimen or with TAF FTC in people with obesity and HIV infection. This was a multi-center open-label randomized superiority trial to test the hypothesis that switching away from an INSTI regimen to doravirine would lead to loss of weight. The primary outcome was the change in weight at week 48. The study was powered to detect as small a difference as of 5% difference between the doravirine and INSTI arms. And the study recruited participants who were adults receiving an INSTI plus TAF FTC for at least 48 weeks and had BMIs of at least 30 kilograms per square meter. One potential weakness in the study design upfront is that it didn't require that people had recently gained weight because of a recent start of an INSTI-based regimen. So some people might have had a higher weight for quite some time. And then secondary outcomes of the study included virologic failure and safety. For the people who changed to doravirine plus PAF, there was a loss of about 0.5% of the body weight. Those who changed to doravirine plus TDF had a greater loss of weight at 2.7%. And those who stayed on the INSTI regimen plus PAF actually did lose some weight as well, interestingly enough, of about 1.8%. So all three arms had weight loss. And there was no significant difference in the weight change associated with switching to doravirine plus TDF or doravirine plus TAF, as compared to continuing an INSTI with TAF FTC. That was a surprising finding. If we look at the pairwise comparison, so here we are looking at each doravirine arm individually as compared to the INSTI TAF arm. For those who switched to doravirine plus TAF, that slightly favored the INSTI arm in terms of weight change, but that was not statistically significant. And conversely, those who switched to doravirine plus TDF had a slightly greater weight loss compared to the INSTI arm, but again, not statistically significant. The safety parameters did not show any significant changes following the switch. There was no impact on creatinine clearance, hip or lumbar bone mineral density, and no differences in virologic failure. So the main takeaway from this study is that we really need to continue searching for other strategies to help our patients reduce weight gain and any complications associated with weight gain in people with obesity and HIV. And now, shifting gears to another intervention strategy, this time for HIV, HPV-related disease. So we will talk about the TKN study, which was a randomized trial of topical trichloroacetic acid versus electrocautery for anal intraepithelial neoplasia in people living with HIV. This was a multi-center, open-label, randomized, non-inferiority trial of adults with HIV infection who had clinically visible and histologically confirmed AIN. And they were randomized to treatment with either TCA or ECA. All the participants were assessed at weeks 4 and 24 after the end of treatment. And treatment was administered at baseline and then at several time points throughout the study, unless their AIN had cleared, in which case they did not continue to receive any additional treatments. So the primary endpoint was therapeutical success at 4-week follow-up, defined as a complete clinical response by high-resolution endoscopy with histologically confirmed resolution of AIN or its regression. This was done by a non-inferiority analysis. The primary efficacy analysis was conducted in the intention to treat population with sensitivity analysis done in the protocol population and with the several additional secondary endpoints. So looking at the main outcomes at 4 weeks of follow-up in terms of complete clinical response with histological clearance or downgrade, the response rate was just about 53% in the TCAR and just under 62% in the ECAR. And although those differences look numerically different, with a difference of just under 10%, there was not a statistically significant difference. There were similar rates of histological clearance or downgrade. And there was, in the intent to treat population, a significantly higher rate of complete clinical response in the ECAR, as you can see there. And if we look at the 24-week outcome, again, the differences here are now nearly spot on 51% and 49% respectively. So because of the differences seen here, the TCAR group did not meet the criteria for non-inferiority compared to ECA at the 4-week primary endpoint, but it was indeed non-inferior at 24 weeks. So the TCA group required significantly more interventions to achieve clinical success as compared to the ECA. There was similar safety in the two groups. Roughly 2/3 of participants experienced an adverse event, and there were no treatment-related SE. And only a single participant discontinued the study because of an adverse event. And that was in the ECA. Investigators conclude that TCA is a well-tolerated, cost-effective, and simple treatment for AIN and people living with HIV, which over 24 weeks may have similar outcomes, but not at the earlier time point of week 4 or 4 weeks. The key takeaways from studies on patient management. First, in the ACTG 5391, the DUET trials, switching to a doravirine-based regimen with or without TDF in people with obesity did not result in a significant weight change compared to continuing an INSTI-based regimen with TAF FDC after 48 weeks of follow-up. And secondly, in the TKN study, topical TCA offered comparable efficacy to the standard of care treatment that was electrocautery for the management of anal intraepithelial neoplasia in people living with HIV. Although TCA did not meet non-inferiority at 4 weeks, it was indeed non-inferior at 24 weeks and had similar safety and better tolerability in some aspects.
Thank you to our expert faculty, and many thanks to you, our listeners, for joining us. To see and hear more from our official conference coverage of IAS 2025, see the link in the show notes. And to hear even more, subscribe to the CCO Infectious Disease channel on your favorite player. Thanks so much. See you on the next podcast soon.